um, amenable, more useful for the society as a whole. For furthering this prevention, there are some ideas which we can impart, which include in our programs. These are the photographs which were taken during our 75 years of celebration in our college. We had a Science of Life exhibition. Certain exhibition like this can spread the public awareness for making the people aware regarding cardiopulmonary resuscitation. More and more installments of automatic external defibrillators can be useful in saving precious lives. Again, this is a photograph from the same exhibition where we made sure that the schools in and around the Jaipur city, they visited the exhibition, Science of Life exhibition, and emphasis was made regarding they were made aware about the disease processes and the preventive programs. The regular screenings during the schools, during the school years can of course be taken and can go a long way in providing improving the preventive aspects of the cardiovascular disease. Yesterday there was a lot of talk about the tobacco prevention, and there should be strict laws, especially near the workplaces and the schools where the vulnerable age group, and the strict laws regarding tobacco prevention, and tobacco tax should be increased to prevent these people, prevent the children to use this tobacco and their products. So, in the end, I would like to conclude by saying that prevention and management of cardiovascular disease has significantly evolved over the last few years in the state of Rajasthan, as we have seen. Healthcare services are now available and the medicines have improved the healthcare awareness amongst the public. But for the long-term sustenance of this, it is essential to strike a balance between providing accessible healthcare to all and addressing the challenges of a free healthcare system. Preventive healthcare framework can be further strengthened by public participation in CPR trainings, educating school children about smoking and nutrition, routine health checkups, and implementation of laws to check tobacco and smoking. And finally, policymakers and we as doctors must consider these factors when designing, implementing, and delivering these healthcare facilities to ensure that they are sustainable and effective in meeting the healthcare needs of the population. Thank you. Thank you for your attention.
Thank you, Rajiv sir. For our next talk, that is hypertension guidelines by Indian Society of Hypertension, I invite Dr. Anuj Maheshwari sir to deliver this talk. Thank you, sir.
Thank you, chairpersons, for the kind invitation. Thank you, Dr. Rajiv Gupta, for giving me this opportunity to present these guidelines which we have made in leadership of Dr. Rajiv Gupta as a president of Indian Society of Hypertension. So I shall be giving a brief account of these guidelines. As you can see on the screen, these guidelines has been structured in 13 chapters, and these chapters has been given to the respective experts of those subjects, and they have designed and collected the data, and finally they made their recommendations. As you all know that hypertension is responsible for 10 to 12% of the all-cause mortality across the world. In India, hypertension affects 32.6% of the women and 38.7% of men over the age of 20 years. So as a mission of the Indian Society of Hypertension, we led this campaign to control elevated blood pressure and its associated complications, and taken a responsibility of creating these clinical guidelines inspired by the International Society of Hypertension. The unique challenge was there to make them in Indian context with the backup of the Indian data, which was lacking in many segments. So we tried to make as a template of the International Society of Hypertension and fixed up the Indian data wherever we could get, and where we didn't find the Indian data, then we followed the same International Society of Hypertension guideline. About 5 clinical experts were the overseers of these guidelines, 2 advisors, and section-specific committee has been formed, 3 to 6 experts, all 13 sections each. have been taken. The first section 3, in which hypertension definition has been given. Following the same, what Dr. Neil Poulter has said, that 140/90 should be the diagnosis for the hypertension, but we tried to make it more India-specific, because the Indian population is having more vulnerability towards some metabolic disorders. So, diagnosis of the hypertension, grade 1 hypertension is obviously at the 140/90 is the cutoff, but 130 to 85 is taken as a high normal blood pressure, and less than 130 and less than 85 has been considered as an optimal blood pressure. All adults above the 18 screened during the interaction with any healthcare professional should be checked for their blood pressure, and if they are found to be in the high normal or grade 1 blood pressure, they should be counter-checked with the 7 days reading of the out-of-office blood pressure measurement, that may be the home blood pressure monitoring or ambulatory blood pressure monitoring. Every time whenever a patient comes to the clinic, he should be waited for the 5 minutes before checking the blood pressure, and then it should be checked in both the arms. At least 3 readings should be taken, and averaging of the last 2 should be considered. The 3 methods of the measurement of the blood pressure have been found to be useful and recommended. That one is the office blood pressure measurement, then home blood pressure measurement, and finally the ambulatory blood pressure measurement, which is considered as a gold standard and is helpful in ruling out the nocturnal hypertension, marked hypertension, and white coat hypertension. The section 5 says how to go with the diagnosis, investigation, and additional examination. Section 6 is giving us an idea about the cardiovascular risk factors examination. In this, the diagnostic approach, cardiovascular risk factors and cardiovascular risk scores has been given the idea of that, and they have been compiled in the evidence of the, in the light of the evidences available to us. The recommendations for this diagnostic workup regarding this cardiovascular assessment has been that in the form of the workup as suggested on the previous page. Then cardiovascular risk is to be assessed from the risk factors regarding age, sex, heart rate, increased body weight, and associated comorbidities if they are there, and level of the dyslipidemia. Patients, those who are having the coronary artery disease, they are suggested to keep their blood pressure less than 140/90, less than 130/80, and they are diagnosed to be having hypertensive more than 140/90, they are suggested to be target it at less than 130/80. 140/80 was for the elderly patient. The same was for the stroke, and same was for the heart failure, but there was a consideration, there was a rider for the heart failure that people should not go beyond 120 and 70 for the blood pressure lower. Chronic kidney disease was having the same, and chronic obstructive pulmonary edema has also kept the same. Hypertension-mediated organ damage should be checked whenever the blood pressure, whenever the patient comes for the first time in the clinic with hypertension. And for that, exacerbators and inducers has to be enumerated. And treatment of the hypertension, which is the most important part of this guidelines, for any guidelines which is really relevant for any clinician, was grade 1 hypertension. You can start with the monotherapy, but it's instead of the up-titrating the monotherapy, it is recommended to add another medication whenever it is not controlled on the monotherapy. Grade 1 hypertension, but all the time whenever it is being started on a pharmacotherapy, lifestyle intervention should always be given a chance at least for 3 to 6 months before starting the treatment in high normal and grade 1 hypertension. As far as the grade 2 hypertension is concerned, dual therapy is to be started together with the lifestyle intervention without waiting the lifestyle intervention is working enough or not. In grade 2 hypertension, again the combination therapy, dual drug or may be required to be the triple drug, may be started together with the lifestyle intervention. So the blood pressure lowering in the intensive method is recommended. Lifestyle modifications are kept revolving around the weight reduction, promoting the diet which is rich in vegetable, fruits, beans, nuts, seeds, and vegetable oils, fish, and poultry, and promoting the regular physical activity, structured exercise, reducing the sedentary behavior. All these are the cornerstone of the lifestyle modification. Once the comorbidities and complications of the hypertension and its management are concerned, these are enumerated here in the form of the cardiovascular disorder, CAD, heart failure, atrial fibrillation, valvular heart disease, cognitive impairment, vascular disease may be the lower extremity arterial disease, aortic dilatation, other comorbidities may be the psoriatic arthritis, glaucoma, hypertension, oncology, and hypertension management during follow-up. So if the cardiovascular disorder is concerned, the recommendations were to begin drug therapy in the grade 1 hypertension if it is more than 140 and 90 in adults with or without CAD along with lifestyle changes. High normal BP may warrant drug therapy if lifestyle modification doesn't work till 3 to 6 months. CAD and therapeutic goals have been decided and is to be tried to achieve for the first with the ACE inhibitors or ARBs. An Indian patient tachycardia remains a problem, and see if the patient is also having the CAD, then beta blockers could be a associate for the ACE inhibitors and ARBs, and sometimes they can be the initiators too. The medical considerations may be avoiding the concurrent use of the beta blockers and non-dihydropyridine calcium channel blockers together. Patient with very low heart rates should not be initiated on the beta blockers, and hypertension and heart failure should be taken into the consideration with the use of the diuretics. Alpha-1 blockers can be used in combination with the beta blockers, and thiazide-like diuretics for heart failure prevention. SGLT2 inhibitor has been especially mentioned even if the patient is non-diabetic, then patient having a heart failure from all over its spectrum can be initiated with the SGLT2 inhibitors. Cerebrovascular disorder, we have given the clear-cut idea for how long it should be accepted, especially if a patient is coming with the hemorrhagic stroke, then we should aim for the blood pressure keeping less than 140/90 within 6 hours of the symptoms onset to prevent hemorrhage expansion. Slow and moderate reduction, which should not be very much aggressive, to 180 mm of mercury are advisable for systolic blood pressure if it is more than 220 mm of mercury. Ischemic stroke management has also been given the guidelines that patient those who are eligible for the mechanical thrombectomy or IV thrombolysis should maintain their blood pressure less than 180 or 100/105 mm of mercury for the first 24 hours post-intervention. Clinical judgment is crucial when considering pharmacological therapy for blood pressure reduction less than 15% within 24 hours of the non-IVT or non-MT candidate with blood pressure more than 220/120. Ischemic stroke and thrombolysis lower the blood pressure to systolic less than 185, diastolic less than 110 before initiating thrombolysis. So these guidelines has been given the all conditions of the stroke where the blood pressure and how much the blood pressure is to be maintained. Similarly, the kidney disorders, as already said, the cutoff should be the 140/90. Yes, I'm finishing it. It was really a long thing, so covering for every aspect, it is difficult to finish in 10 minutes. So diabetes mellitus, obviously the role of SGLT2 inhibitor has been fixed up here, but apart from that, the blood pressure, for the blood pressure lowering, the starting treatment should be with the RAS blockers. But here the more important thing in diabetes patient, nighttime blood pressure monitoring. And that is to be done by the ambulatory blood pressure monitoring, because home blood pressure monitoring is not sufficient to keep track for the nocturnal lowering of the blood pressure. Special circumstances like resistant hypertension, secondary hypertension, crisis, asthma, elderly, acute stroke, diabetes. We have also taken one chapter dedicated to the hypertension in women because this is most of the time remains neglected, and because of their hormonal changes across their life, they may be having different issues in their hypertension management. Endocrine hypertension, obesity has been introduced as one important chapter with the hypertension management with its recommendation. Technology has also been given a place in these recommendations. Also, we have taken the technology causing hypertension as well as technology can be helpful in prevention of hypertension. Pediatric and adolescent hypertension has also been given the place in these guidelines with the recommendation of the blood pressure level should be evaluated in children from 3 years of the age. Finally, the hypertension management at a glance has been given a flow chart through which the clinician, those who are not having enough time to go through the complete guidelines, to read those guidelines, they can have an idea about the management of hypertension in their clinics through this flowchart. Thank you very much for your kind listening.
Thank you, Doctor, for the excellent overview. Just small one question for acute ischemic stroke. What's your target blood pressure in first 24 hours? For acute ischemic stroke?
Yeah, I have given in my guidelines.
No, most of the neurologist colleagues, they are still afraid of reducing it less than 90. They are comfortable with 150, 90. So what's your take-home message for first 24 hours acute ischemic stroke? Should we not go below 90?
Yeah, it should not be, in the first 24 hours, it should not be going very low. It should not be less than 15% reduction of the blood pressure in which the patient has been found for the first time. So if the patient has been seen in a 220 by 180, we should not bring it down less than 185. So it is the important, and it has already been mentioned here.
Thank you, sir. So we invite.
Would be happy.
Congratulations on pulling that together. I realize how much work that must be. Despite the speed that you had to present that at, I spotted the fact in lifestyle modification you did not recommend salt restriction. And I'm afraid that is a fundamental error. There has been some questionable epidemiology to suggest that in a population level there may be a low point. I think it's flawed, it's inappropriate, but there is some evidence. There is decades of evidence showing that at the population level we should lower salt. In the context of hypertension, there is absolutely no doubt that patients should have salt restriction. And I was very sorry to see that.
As far as the salt restriction is concerned, we have included in our guidelines the salt restriction.
Oh, good.
And,
It wasn't there on
but
the...
it was, I think, very fast flowing the slides. I might not have spoken that, but it is written there.
Then
that
I'm
salt
happy.
restriction is there, and we are focusing on the salt restriction.
I saw
2.6.
potassium enriched. I saw increased potassium. I didn't see reduced sodium. I'm sorry if I missed it.
No, it's okay. Thanks for the reminding, but it is very well kept in the guidelines, and we are focusing on the 2.6 gram of the salt intake in a day.
Thank you. Apologies.
Thank you, sir. Now we invite our last speaker, Dr. S.K. Sharma. Dr. S.K. Sharma, sir, for the talk on the diabetes and CAD prevention, use of tailored approaches and diabetes drug combinations. Last but not the least, this is going to be a very important, interesting talk.
Well, I think only chairpersons are there and few of the brave people are there for this last lecture. Thank you very much for Dr. Gupta and his team for inviting me. I will be very, very fast. Well, dear friends, we all know that cardiovascular disease patients are suffering from huge burden of diabetes and metabolic syndrome. So we'll be highlighting few of these aspects of management of diabetes in our day-to-day practice, as well as those who are suffering from cardiovascular disease also. So in India, we have something like 10% of our population suffering from type 2 diabetic patients. Our patients are heterogeneous. They are coming in young age, middle age, and elderly. There are also high incidence of this disease in our young patients, as well as female patients are also having huge burden of diabetes. As the BMI of our patients are increasing, we find that large number of our patients are developing very high risk of diabetes, and you find that goals of treatment are significantly tighter now. We have guidelines directing us to reach a HbA1c of 6.5 or 7. According to the comorbidities, we even can go to a picture of 7.5, or even in elderly and frail patient, HbA1c of 8 may be there. But most of the time, diabetes is a disease which is characterized by progression. So multiple drugs are required, and combination therapies having different mechanisms of action complementary to each other and reducing the occurrence of hypoglycemia and weight gain are now preferred. And of course, there are large number of oral drugs which are having, you can say, fixed dose combination, which will be helpful in reducing the pill burden and improving the adherence to the treatment. So rationale of combining two group of drugs like SGLT2 inhibitors and DPP4 inhibitors are clear-cut there. You have one drug which is acting through the kidney and causing glycosuria and decreasing hyperglycemia, weight, as well as hypertension. On the other hand, you have DPP4 inhibitors which are having action at the level of alpha and beta cell in the pancreas and causing increase in insulin and decrease in glucagon. And together, if you see, one drug is reducing glucagon, other is increasing. So overall, they are nullifying the bad effect of each other. And there are incidences where the genitourinary infection, if you are using only DPP4, you will find when you are combining DPP4 with SGLT2, the chances of these complications are less. So complementary mechanism of action is there. So you have better HbA1c reduction, fasting postprandial, and minimal hypo and weight gain. So we all know dapagliflozin is now considered to be a drug for cardiologists and nephrologists in addition to diabetologists. So it is highly potent, 0.8% HbA1c reduction, weight reduction, and causing blood pressure reduction, as well as cardiovascular and renal risk reduction is also there. It is now considered to be one of the first line of drug in the patients of where you have heart failure, and you all know the different mechanism of action of dapagliflozin working at the level of the kidney, circulation, heart. There was a beautiful editorial by Dr. Subodh Verma highlighting the pipes, pumps, and filter, where the drug is acting on the cardiovascular events, reduction of the atherosclerosis, as well as improving the renal function. There is a landmark study by the name of Declare-TIMI, and here the patients were 65% were having high risk for the development of heart disease, and the other 30%, 35% were having pre-existing atherosclerotic disease. And in these type of patients, when you use dapagliflozin over the standard of treatment, you find that there is a significant reduction in MACE. Primary safety endpoints were there. Secondary outcomes were in the form of significant reduction in heart failure hospitalization and renal impairment. Although, because the patients were not very sick, so you find that the reduction in MACE was not significant, but the heart failure hospitalization was significantly reduced, and renal impairment was significantly retarded in this patient. Looking at the results, they extended the study to patients with CKD, where both diabetic as well as non-diabetic patients were given 10 milligram of dapagliflozin, and you find that there was a significant reduction, 39% reduction of primary outcome, 34% reduction in secondary outcome in the form of 29% reduction in renal outcome, and all those things were indicating that this drug is retarding the progression of kidney disease in our diabetic patients as well as non-diabetic patients. Similar to that, they have extended the drug use in a trial where they have DAPA heart failure. Again, diabetic as well as non-diabetic patients were given 10 milligram of dapagliflozin, and here again you find that cardiovascular mortality and heart failure was significantly reduced in these patients, both in diabetic as well as non-diabetic. Looking into the sub-analysis, you find that the drug is equally effective in elderly patients in our usual practice, in renal impaired patient, in hepatic impaired patient. The drug is again having similar effectiveness, and the chances of side effect profile was significantly lower. Diabetes is a progressive disease. Most of our patients are on combination of drugs. So linagliptin, a DPP4 inhibitor, which is not metabolized in our body, not excreted by the kidney, but by the liver, is a useful drug where you can use it in all the different stages of chronic kidney disease. And there was large amount of data there, and as a DPP4 inhibitor, it is working similar to other DPP4 inhibitors. And there was two landmark studies. One is by the name of Carmelina, where large number of patients who were having long duration of diabetes, suffering from significant cardiovascular and renal problem were included. And the other was Carolina trial, where the drug was compared to glimepiride. These are the patients who are having shorter duration of diabetes and they are relatively healthy. So looking into Carmelina, you find that this linagliptin is cardiovascular safe. Once we say safe, it means it do not cause increase in cardiovascular events, may not be providing any benefits, but not causing any harm. And it is hospitalization for heart failure was reduced by tune of 10% as compared to increase of 26% by saxagliptin. So here it was not significant, just missing the, you can say, significance by a narrow margin. But again, it was can be given to a large number of our diabetic patients with kidney impairment. There was clear-cut definition of, you can say, safety aspects. So drug can be given to mild, moderate, and severe renal impairment, and to kidney, to liver impairment also. And once you look into this combination of DAPA plus linagliptin, there are clear-cut studies looking into the good effect of this combination. Where to use them? I think looking into the HbA1c of your patients, you find that patients who are having a HbA1c of more than 8%, you can bring this combination. If the patient is already on metformin and your patient is having more than 9%, then you can add this combination with metformin. If metformin patients are having HbA1c of 8 or so, even then you can bring this combination. The good point of this combination is that they do not cause hypoglycemia and they do not cause weight gain. Significant improvement in glucose profile is there, and you can provide this combination to large number of patients. The single caveat will be, once the estimated GFR is below 25, usually these SGLT2 inhibitors are not recommended, and otherwise most of the renal trial, most of the cardiovascular trial are telling us that although the estimated GFR is going down, the glycosuric effect may not be that effective, but the cardiovascular and renal profile of these patients are significantly improving once you are using this combination of a DPP4 and SGLT2 inhibitor. Safety aspect, again, except genitourinary mycotic infection, most of the time you find these drugs and this combination is safe. When to initiate, as we discussed, this combination can be given looking at the HbA1c of your patient and whether the background drugs are metformin or metformin plus glimepiride or so. Accordingly, look at HbA1c. If it is more than 1 or higher, then you can bring in this combination in large number of your patients who are suffering from renal impairment, liver impairment, and also having heart failure in your cardiac patients. So rational combination is there. It is effective combination. It is having some extra glycemic effect, target multiple pathophysiology of diabetes, low risk of hypoglycemia, reduced pill burden, and overall cost of the therapy is also reduced. I think this is the super fast expression looking into the time for lunch. Thank you very much.
Ask just one question.
Please.
Why don't you combine statin also with this?
What is?
Statin. Combination of statin with diabetes pill.
Combination of statin with
Diabetes drugs.
diabetes. Well, all the type 2 diabetic patients are considered to be in a moderate, high, or a very high risk. There is no diabetic patient who is in low risk. So all the patients require statin. So once you are combining this drug with dapagliflozin, there was an article by Dr. A.K. Singh. He says that this drug should be mixed in the water supply of the city, dapagliflozin as well as statin. Thank you very much.
Thank you very much, sir, for the excellent overview. Right, sir. So we close this session. I invite Dr. Rajiv Gupta for the closing.
Thank you very much. Thank you very much for the nice session. So memento time, please. Can I invite the speakers? Dr. Surendra Sharma and Dr. Arvind Mathur to do the... Dr. Anuj Maheshwari. Dr. Rajiv Bagahatta, please. Dr. Nikhil Parchode. And Dr. Neil Poulter. Dr. Kaushik, I think he is left. No, but you got yesterday.
Now the last, we have made some results for our poster presentations. So after the final decision of judges, the first prize goes to Dr. Navida Babbar for the poster presentation. Please come on the stage. Second prize goes to Parth Dharmesh Mashru. He is from Mahatma Gandhi Medical College. And third prize, Aditya Goyal. Please come. I will request Dr. S.M. Sharma, sir, to facilitate.
Now, Dr. Kushal, Dr. Kushal Madan.
Now I would like to thank all the pharmaceutical companies. They have contributed for this successful conference. I would like to thank Dr. Deepak Maheshwari, Dr. Sunil Sharma, Dr. Gaurav Singhal, Dr. Pradeep Meena for their untiring effort to bring this conference to the success. Now I would like to call upon Translumina, people from Translumina, one of the representatives should come. Translumina. Nobody? कौन आ गया? Medtronic. आ जल्दी Medtronic. Torrent. Boston Scientific. Ace Cardiopathy. Abbott, Novartis, Biotronic, MacLeod, USV, Sun Pharma, Intas. Please come. Merrill. Wellron, Fidus, Pfizer, Corona, Glenmark and St. Jude. conclude this
Uh,
conference.
so, thank you all. And now we conclude this conference. And thank you for your participation. Thank you so much.
इसको